Hello, my name is Frank Zerba, and today we will be talking about pneumonia and tracheitis, primarily in the pediatric population. I have no financial or other relationships to disclose regarding this presentation. During this presentation, I will describe the pathophysiology of pneumonia with a focus on pediatrics, as well as the pathophysiology of bacterial tracheitis. We will review the common pathogens associated with both disease states, and then discuss the appropriate treatment regimens for both infections. We will start with pneumonia. Pneumonia in the pediatric population shares many similarities with adult pneumonia. We will discuss some of the major differences to help those unfamiliar with pediatrics navigate the nuances of these differences. As a quick refresher for everyone, pneumonia is an acute infection of the lung tissue. It can affect any of the lobes of the lung and results from a host of different clinical conditions. Generally speaking, pneumonias result from a failure of host defenses to remove either the offending pathogen or the presence of material that weakens the host's ability to clear the infection. Pneumonias can result from bacterial, viral, or mycobacterial sources, as well as fungal pathogens. The specific pathogens vary based on age and exposure location. Patient's age plays a large role, as well as we will discuss, in determining which pathogens are most likely and which antimicrobials to use to manage the infection. The selection of agents and dosing can also vary based on local susceptibilities and exposure sources, such as community, hospital, aspiration, or ventilator. And as with most clinical situations, host factors play a significant role in determining treatment. Patient allergies, prior infections, home life, baseline clinical status, and individual response determine how severe the pneumonia may become and how aggressive the treatment will be. Pneumonia presents very similarly in most pediatric and adult patients. Whether pediatric or adult, patients will generally present with cough and fever, similar to other respiratory tract infections. There may be pronounced tachypnea and potentially tachycardia. In pediatric patients, retractions or belly breathing is commonly seen and is one of the many reasons why pediatric patients may present with exhaustion. Nasal flaring and grunting are commonly seen in infants and neonates. And because neonates are obligate nasal breathers, if the pneumonia is concomitant with a URI, this may lead to increased distress in the neonate and decreased oxygenation. When examined, there will typically be abnormal lung sounds, including crackles or rales, wheezing, and potentially rhonchi. Stridor would be an uncommon sound, as this is more indicative of croup than pneumonia. Guidelines recommending obtaining a chest X-ray in resource-rich settings to help identify infiltrates. Infiltrates tend to be unilateral and in specific lobes. However, in more severe cases, multiple lobes and bilateral infection can be seen. Hypoxia can be seen in more severe cases, especially those with a more prolonged disease presentation, or in younger patients who have less reserve to handle any decreased oxygenation status. Microbiological confirmation through a bronchoalveolar lavage would be the most likely to provide a definitive pathogen, but it is an uncommon procedure, as it can worsen respiratory status by irritating the lung and decreasing oxygen transfer. Endotracheal aspirates, sputum samples, and blood cultures are commonly obtained, but all have their limitations. Endotracheal aspirates and sputum samples can either be contaminated during the procedures or select for colonizer bacteria that are not actually causing the condition and lead to inappropriate antibiotic choices. Blood samples are unreliable unless in severe cases where the patient has proceeded to sepsis and the bacteria has spread further throughout the body. MRC nasal swabs can be useful to minimize vancomycin exposure, and viral respiratory panels can help to minimize antibacterial use if the clinical presentation and the identified virus align. Antimicrobial therapy, therefore, should be directed at the most likely pathogens and adjusted based on the clinical presentation and available microbiological data. We'll start with community-acquired pneumonia, the one that is most likely to be seen in pediatric patients. While the criteria for pediatric CAP is very similar to adults, such as the infection must occur in a non-healthcare setting, there are significant differences. Unlike in adults, the potential pathogens and treatments, which we'll discuss shortly, may vary with the patient, as pediatric patients have different communities based on their age that they are exposed to, and the susceptibility of those pathogens that they're exposed to will differ. Data on the potential length of therapy and determination on inpatient versus outpatient is growing, but lags behind adult data. You may notice that the recommendations for length of therapy are similar to older adult recommendations. This is a common theme in pediatric care, as data tends to lag behind in pediatrics due to fewer studies being completed. Individual clinicians and institutions should use their own clinical judgment when applying adult data to pediatric patients. One bright spot is that the introduction and use of vaccines has decreased the incidence of many targeted pathogens. With the pneumococcal and H. flu vaccines, there has been an overall decrease in the incidence of these bacteria causing pneumonia in pediatric patients. The influenza vaccine has also caused a decrease in the occurrence and severity of pneumonia secondary to a flu infection. The vaccines have, however, shifted the type of some of these bacteria, specifically H. flu and strep pneumo, so the continued expansion of vaccines and vaccination is vital to minimizing the hospitalization of pediatric patients for these pathogens. Our empiric antimicrobials will be targeted towards the most likely suspected pathogens. In our neonatal population, ampicillin and gentamicin are the recommended agents. This is similar to the management of neonatal sepsis. Neonates will typically require hospitalization for the complete course of their antibiotics due to their susceptibility to worsening status. Patients less than 2 years old are typically infected with a viral cause and will only need supportive care. If antibacterial coverage is needed, then the regimen for those less than 2 and those between 2 and 5 are similar. Ampicillin alone is needed in fully immunized patients and should provide sufficient coverage. In patients who are not up to date on vaccination, it is recommended to use ceftriaxone, as this will cover for all possible pathogens. Step-down therapy or outpatient therapy can be completed with amoxicillin for those fully immunized, or amoxicillin clavulanic acid for the incompletely vaccinated. If the patient has had prior infections or exposed to ampicillin or amoxicillin recently, it is reasonable to use ceftriaxone or amoxiclav in patients who are already vaccinated. Once the patient is older than 5, azithromycin for atypical coverage is added to either ceftriaxone or ampicillin inpatient, or amoxicillin clavulanic acid for step-down outpatient therapy. Oseltamivir does have dosing down to 2 weeks of age, and if administered early enough may be beneficial, especially in younger pediatric patients. It's important to note that this is not an all-inclusive list, and there may be some clinical situations where alternative antibiotics may be more appropriate. This table shows recommended doses for our empiric antibiotics. There may be some variation due to institutional policies, and those should be followed when appropriate. Ampicillin and gentamicin dosing does vary in neonates and is based on postmenstrual and postnatal age. In the table provided, the dosing is for a full-term neonate, and for any patient that is not full-term, an appropriate drug reference or institutional policy should be consulted. Generally speaking, full-term neonates being treated for pneumonia would receive 50 milligrams per kilogram every 6 hours, and gentamicin at 4 to 5 milligrams per kilogram every 24 hours, utilizing extended interval dosing. This is not the same as high dose once daily seen in adults, and levels should be drawn around the third or fourth dose. In infants and children prescribed ampicillin, 50 milligrams per kilogram every 6 hours is a common dosing regimen. However, in some cases, up to 400 milligrams per kilogram per day in divided doses may be used if there's a high rate of resistance in the community. Ceftriaxone has historically been contraindicated in patients less than 28 days, and this is due to the risk of bilirubin displacement from the albumin, leading to hyperbilirubinemia and kernicterus. However, newer guidelines are starting to suggest earlier use of ceftriaxone. In the recent AAP evaluation and management of well-appearing infants 8 to 60 days old, guidelines recommending using ceftriaxone in some patients over 3 weeks of age. Please refer to your institutional standard if you're using ceftriaxone in a neonate less than 28 days. Ceftriaxone should also not be given in the same line as calcium-containing products, as it can precipitate out and lead to lung damage. Dosing for amoxicillin and amoxicillin clavulanic acid is at the higher end of dosing to account for any potential resistance. Amoxicillin clavulanic acid is dosed based on the amoxicillin component, and it is very important when dosing amoxicillin clavulanic acid that the correct concentration is selected. Products with more clavulanic acid to amoxicillin are preferred for lower dosing strategies such as cellulitis or similar infections. Products with less clavulanate to amoxicillin are preferred for the higher end of dosing and used in infections like pneumonia and acute otitis media. If the wrong product is selected then the patient will be exposed to more clavulanic acid, which could potentially result in osmotic diarrhea. It's important to consult a drug reference to confirm the appropriate ratios when selecting your amoxicillin clavulanic acid product. Azithromycin should be dosed similar to adults, with a higher dose on day 1 and the subsequent 4 days being at half that dose. It's important to ensure that unnecessarily long courses are not ordered, such that the patient would receive 7 to 10 days when a 5-day course would be sufficient. Oseltamivir's dosing is based on the patient's age and weight, and a drug reference should be consulted to confirm dosing due to the complexities involved. In most cases, oseltamivir should only be given within the first 48 hours of symptoms, due to the poor benefit beyond that in most clinical situations. An important question to answer is, when should a pediatric patient be admitted to the hospital for management of their pneumonia? A pediatric patient should be admitted to the hospital for pneumonia when they show significant signs of respiratory distress. This is defined as age-specific tachypnea, retractions, grunting, or nasal flaring, especially in neonates and infants, apnea, altered mental status, and oxygen saturation less than 90% on room air. Any patient less than 6 months old should likely be admitted. If there is a high suspicion for resistance or a history of a difficult to treat pathogen, then the patient should likely benefit from an hospital admission. The care team should also assess the ability of the patient to receive the needed care in the outpatient setting. There can be many factors that play into that determination, but can include the ability to obtain the med, ability to effectively administer the med, as well as an understanding of the severity of the clinical situation. In determining the appropriate length of therapy for pediatric community-acquired pneumonia, we must look at older guidelines. Currently, the guidelines recommend 10 days of therapy. This aligns with recommendations that had been previously given for adults as well. As we may be aware, newer recommendations are coming out that shorter courses of antibiotics may be appropriate for adults with pneumonia. The work by Same and colleagues and the Scott-Cap trial are working to align pediatric information on the appropriate length of therapy in pneumonia with adults. Both trials suggest 5 days may be appropriate. If going with a 5-day course, it's important to ensure that there is appropriate follow-up and that the clinical picture fits this length of therapy. Empiric management of VAP and HAP should begin with the consultation of the local antibiogram. The resistance patterns there will help determine whether some of the choices discussed will be less desirable due to your local susceptibilities. The antibiogram may also help you determine whether you need to provide coverage for MRSA. If there's a low rate of MRSA, then vancomycin may not need to be added, and a single agent regimen may be used depending on the gram-negative susceptibilities at your institution. Other hospital-based or healthcare-based factors play a role in determining whether MRSA coverage is required. Use of IV antibiotics in the last 90 days, an IV catheter placement, the prevalence of greater than 20% MRSA in the patients on the unit can all contribute to whether or not vancomycin needs to be added to a regimen. Patient characteristics, including their underlying medical condition, MRSA colonization, or history of drug misuse or abuse, can help increase the need for vancomycin to cover any MRSA infections. MRSA nair swabs can also be helpful in decreasing the use of vancomycin, and if the patient is not found to be positive on a nair swab, then the suspicion for MRSA being the causative pathogen in the pneumonia may go down and result in being removed from the regimen. Gram-negative coverage should be targeted to ensure pseudomonal coverage. Piperacillin tazobactam, cefepime, and ceftazidime, along with meropenem, are all guideline-recommended agents. Each of these have their own place and will be discussed shortly. When treating VAP, anaerobe coverage should be included as well to cover for any possible mouth anaerobes or other potential anaerobes that may be causing the infection. For gram-negative coverage, the cephalosporins cefepime and ceftazidime are recommended. However, neither provide anaerobe coverage. Cefepime does provide some gram-positive coverage, including MSSA. Cefepime for pneumonia is typically dosed every 12 hours. However, dosing up to every 8 hours can be used and is frequently seen in cystic fibrosis patients. Ceftazidime provides weak gram-positive coverage and should be used in combination with a gram-positive agent such as vancomycin. If either cefepime or ceftazidime is used and there's a suspicion for anaerobes, the addition of an anaerobe active agent should be considered. An example of this would be metronidazole. Meropenem, a carbapenem that has broad multi-drug resistant coverage, should really be reserved for situations where resistance requires its use due to the susceptibilities seen. Piperacillin tazobactam provides broad coverage, including anaerobe coverage, and along with cefepime is a common first-line choice. Cefepime, piperacillin tazobactam, and meropenem can all be given as extended infusions to provide a longer time above the MIC, and this may be beneficial in institutions that have higher MICs. Dosing does change in extended infusion regimens, and institutions should have policies on when extended infusions are used and how long those extended infusions are. It is important to acknowledge that while extended infusions have a clear benefit, they do cause some practical challenges. Incompatibilities between IVs can be a major challenge, especially for two known examples of vancomycin and piperacillin tazobactam, which are not Y-side compatible. This may necessitate an additional line or an adjustment in regimen. The patient will also need to be connected to the line for an extended period, which may be a challenge for our younger, more active patients who may get tangled in lines, or it may limit their ability to play. The final agent to consider would be vancomycin. Vancomycin dosing in pediatrics requires more frequent dosing due to the increased clearance in this population. Institutional protocol should be followed when determining empiric doses and with standard approaches for monitoring and dose adjustment. AUC-based residence monitoring can result in decreased drug exposure while maintaining high efficacy. This is tempered by the need for appropriate monitoring and adjustment of these regimens, as well as an increased number of levels initially needed versus a trough-based monitoring regimen. Shifting gears to a much less common infectious process, we'll now take a look at bacterial tracheitis. While there is very limited literature on the topic, the disease state has been described in several different ways using several different names. It has been called pseudomembranous laryngotracheal bronchitis, bacterial croup, and membranous croup. For our discussion, we will refer to it as bacterial tracheitis. While this is seen much less commonly in pneumonia, it does represent a potentially life-threatening upper respiratory tract infection. Bacterial tracheitis is characterized by purulent secretions that have thickened and formed a pseudomembrane. The pseudomembrane can become thick and narrow the airway and potentially become dislodged, completely obstructing the airway. This is the reason for bacterial tracheitis' potentially life-threatening urgency. However, as the literature has expanded, a new theory is that bacterial tracheitis might be better seen as a spectrum of illness, with some patients experiencing more severe manifestations, while others have milder forms that may result in a less severe situation and no risk of airway obstruction. Some suggest that the less severe forms be referred to as exudative tracheitis, while bacterial tracheitis is reserved for more severe presentations. This is to help differentiate the ends of the spectrum. However, there is currently no guidance on which patients might be at greater risk of complication, and caution is recommended whenever treating a patient with suspected bacterial tracheitis. With an occurrence of 0.1 per 100,000 per year, it may be difficult to accurately determine general criteria. The average age of the patients affected has varied with the study period and the specific definition used. Commonly, 4 to 8 years is the core group, with ranges between 6 months to 12 years being included. And as suggested, because of the variability in defining the spectrum, the mortality in the literature varies wildly, with older articles having mortality as high as 40%, while newer articles suggest a low mortality risk, especially if diagnosed and managed early. Due to the nonspecific presentation of bacterial tracheitis, true diagnosis requires more than clinical features, which are often mirrored in other upper respiratory tract infections. Bronchoscopy is the gold standard for diagnosis of bacterial tracheitis and is a cornerstone of management as well, which we'll discuss on the next slide. Any patient with a suspicion for bacterial tracheitis should be considered for bronchoscopy to help determine the presence and extent of the pseudomembranes, as well as the danger of airway obstruction. Chest x-rays can be done initially to help identify other potential causes of illness, and on x-ray, broad irregularities may be visible, but are not always clearly seen and should not be used to diagnose alone. Viral infection will likely be present, and while not diagnostic, seems to be an instigator of further infection and membrane development. In patients with suspected bacterial tracheitis, airway stabilization is of vital importance. Older patients tend to have larger airways that are less likely to be blocked by membranes, so an endotracheal airway may be less urgent, but it should be considered if any clinical decompensation occurs. The traditional approach, and still used in more severe cases, is to do a bronchoscopy with mechanical removal of the membranes. As our understanding of bacterial tracheitis grows, there may be subsets of patients who do not require mechanical removal, either due to their milder presentation or characteristics making them less likely to obstruct their airway. The bronchoscopy for diagnosis is typically immediately followed by mechanical suction to minimize the number of manipulations and expedite the management. And regardless of whether bronchoscopy is completed, directed antibiotics are considered standard of care. The antibiotics should be targeted to common upper respiratory tract infection pathogens based on local antibiograms. Due to the small number of patients in the literature, it is unclear if steroids provide a benefit in terms of length of intubation or hospital stay. However, most authors suggest that the potential benefits of steroids in reducing airway edema, especially early in the treatment course, outweigh the potential risks when used judiciously. As stated earlier, receiving epi does not seem to help with the stridor and should not be given. Due to the similarities in common pathogens seen in upper respiratory tract infections and bacterial tracheitis, you'll notice some patterns in the empiric antibiotics selected. The most commonly used is ampicillin sulbactam, plus or minus vancomycin. Ampicillin sulbactam alone will provide sufficient coverage for most of the suspected pathogens. In patients who present with more severe illness, have a prior history of respiratory MRSA infections, or have a clinical suspicion, the addition of vancomycin would be prudent. Vancomycin dosing should follow institution-specific guidelines. Patients can be transitioned to oral management once they are able to protect their airway and are clinically stable enough, though no definitive criteria exists. Viral infections typically only require supportive care. However, if flu is present and the timing is appropriate, oseltamivir could be considered. There are no recommendations for or against the use of oseltamivir in the later stages. However, the benefit is likely minimal. The length of therapy in the literature for all antibiotics is conservative at 10 to 14 days, which reflects historical pneumonia treatment durations. When managing pediatric community-acquired pneumonia, there are significant differences in the pathogens and treatments based on the patient's age and even immunization status. Ensuring the narrowest appropriate regimen will minimize the side effects while also reducing resistance and saving agents for future use. The length of therapy is currently 10 days, however, emerging data will likely change that and result in shorter courses. Pediatric HAP and VAP management is based on available pediatric and adult recommendations. MRSA coverage is not always needed, and efforts should be made to narrow the regimen if and when cultures are finalized. And finally, bacterial tracheitis is a rare but potentially life-threatening condition, predominantly seen in children. Most of the pathogens are similar to other respiratory tract infections, but the common pathogens may be changing due to increased vaccination. And it is unclear if steroids have a place in therapy and should be used with appropriate clinical evaluation. And further references. Our first question is, CT, a 3-year-old fully immunized male, is admitted to the General Pediatrics Unit for concern of bacterial community-acquired pneumonia. Based on what you know of CT, the best first agent is A, ampicillin, B, amoxicillin clavulanic acid, C, ceftriaxone, or D, piperacillin tazobactam? The correct answer is A, ampicillin. Ampicillin is appropriate in this situation due to CT's age of less than 5 and his fully immunized status. If the patient CT were to be unimmunized or incompletely immunized, ceftriaxone would have been an appropriate first choice. Had CT received ceftriaxone initially and we were looking to step down in therapy, amoxicillin clavulanic acid would have been an appropriate PO alternative. Piperacillin tazobactam is too broad to treat community-acquired pneumonia unless there is a known drug resistance in the patient's past. Our second question is, the gold standard of bacterial tracheitis diagnosis is A, clinical signs and symptoms, B, chest x-ray visualization, C, flexible or rigid bronchoscopy visualization, D, response to initial steroid doses. The correct answer is B, ampicillin sulbactam, which covers our most common pathogens seen in the literature. Vancomycin may be added to ampicillin sulbactam in situations where MRSA is suspected, but ampicillin and vancomycin alone would be insufficient to cover the suspected pathogens.